Arber from Tel Aviv. He's going to give us a lecture on personal aspirin therapy.
Good afternoon. It's always a pleasure to be in Heidelberg. It's maybe my 5th or 6th times here. Wonderful city. And I'm also happy to talk about something is close to my heart. You know, aspirin is good for the heart. And maybe I can convince you that this might be the drug of the century. So do you know that colorectal cancer is preventable? We have heard that it's 1.4 million new cases. I knew 1.2 million new cases. It's a lot. We can do it by lifestyle modifications, early detections, and chemoprevention. Lifestyle modification, it's not easy. Not to smoke, not to drink. And when I'm speaking about physical activity, this is not what I mean. So it's not working. Colonoscopy I'm a gastroenterologist. I make my living out of this. This can prevent maybe up to 80-90% of the cases. However, although we are not using, we have the public votes with its legs against screening colonoscopy. So what we are left is chemoprevention. Chemoprevention is plausible. This is some updated of a review that we had written in gastroenterology about 5 years ago. And in 70 out of 72 studies, the preventive efficacy of NSAIDs, COX-2 inhibitor, and aspirin was clearly demonstrating, preventing adenoma recurrence, reducing the incidence of colorectal cancer, and even reducing mortality from colorectal cancer. But there were some issues regarding toxicity, especially cardiovascular toxicity. Personally, I don't think it was justified, and we do not have time to go into these studies. I was with Bernard Levin, the principal investigator of one of these studies. So what actually we are left with aspirin. And this is interesting. It's taken from 1997 when Bayer came out, and look what he says here. Aspirin does not affect the heart. We not always have to believe the drug companies. So, you know, there is ample of data that aspirin can reduce the risk of recurrent colorectal adenoma. And I also added one recent study coming from Japan. It was published in GATT last month. It's not only in the Western world, also in Asia Pacific, aspirin is working in the prevention of recurrent adenoma. Also, this is some studies where we can see that the relative risk of colorectal cancer in individuals using aspirin, and whatever that is left of this axis is protective. And we can also see that aspirin is protecting. I can show you more data. We can see here that this was a pooled data from the British doctors trial and the UK TII trial, when it was clearly shown that aspirin can reduce colorectal cancer risk. Regular use of 300 milligram reduces it by 26%, and even higher, 37%, if it was taken for more than 5 years. And the benefits were seen after 10 years. And it is important to remember, maybe I'm jumping a little bit ahead, side effects you can see in the beginning, first day, first week, first month, first year. The efficacy is much later. So sometimes it's difficult because when you see side effects, you say, oh, I give a drug to a patient, he has some side effects. But when you're preventing something, it's more difficult to understand. Maybe somebody not feel that sorry because you did not prevent, you will prevent something because it's difficult to understand it and to feel it. So I think this is one of the messages I'm going to allude to it, is that aspirin should be evaluated for the long run. And this is what's given to me by Andrew Chan. And, you know, he published a few papers regarding the nurses' health study and the health professional follow-up study. Now he's in charge. And in these studies, they were collecting data every 2 years, including use of aspirin. And combining these two studies, there was 1,279 cases with colorectal cancer. And the results, it was clearly seen that colon cancer-specific survival was much better among aspirin users. There was a 29% reductions in the mortality from colorectal cancer. And then we are talking about the endpoint mortality, which is the most important thing. And even more important, not only colorectal cancer specific mortality, but also overall survival was better in the aspirin group. So I've shown you that aspirin can prevent adenoma recurrence. It can reduce the incidence of colorectal cancer risk. It can also reduce the risk of metastasis. When patient has cancer, is prescribing to aspirin, the level of metastasis is significantly lower in those patients who are taking aspirin as compared to those who are not taking aspirin. And this is a CAP2 study. John Byrne, as our friend, described, which is very important, and a landmark study that affects our daily life. We should prescribe aspirin to patients with HNPCC, hereditary non-polyposis colorectal cancer, study or a disease that is associated with 85% mortality during lifetime. So this is the first time who shows that aspirin, high dose, 600 milligram, giving for 1 to 4 years with a follow-up of about 4 years, reduce the risk by 38%. Now we are launching and we are going to be part of the CAP3, the continuation effect, and also Nelly and I are trying to make it better by doing analysis and trying to predict, and Nelly is going to tell us later which one is going to respond to the drug, which one is going to develop side effects. And it's not that only colon cancer. As you can see it here, aspirin can reduce the risk of all cancer deaths, and this data is driven from a cardiovascular randomized control trial. And again, you can see that with time, aspirin is effective, and I didn't have enough time, but actually in practicality can prevent almost all cancers, but to lymphoma and bladder cancer, I do not know why, there is slight increase, but all other cancers, all other tumors, aspirin can prevent them or reduce. It's true that there are some side effects, like we know for every drug, some nuisance symptoms, mucosal lesion, and even serious GI complications like perforated ulcer, catastrophic bleeding that needs hospitalization, small and large bowel ulcers and strictures, and even hepatotoxicity. The most important one is bleeding, and as you can see it here, it's also a time of the dose of the aspirin. The higher you take it, the bigger chance that you have. So you know that aspirin on one hand is very effective, on the other hand it has some side effects, and I agree with the mouse. One should take no risk if it's not necessary. We should carefully evaluate the benefit and the risks. And in 1996, Bob Sandler, and I may quote, although aspirin may prevent the disease, it may increase the risk of hemorrhage, stroke, or cause other adverse events. We must accurately balance the benefits and risks of these drugs based on the results of ongoing randomized control trial. It was almost 20 years ago. In 2007, the United States Preventive Services Task Force recommends against using aspirin as primary prevention. And this is taken from just a recent talk from Dennis Hannen that was done in last Digestive Disease Week, the last meeting of the annual meeting of the American Society of Gastroenterology. It is summarized of a talk that all of us had written. Actually, we say the same. We should carefully evaluate the risks and benefits. And ladies and gentlemen, I'm going to show how we can do it. And with the genetic data that Nelly is going to tell you, I think we might have the answer. So we might do some progress. And actually, this is what I'm supposed to talk about, personalized aspirin therapy. I strongly believe that aspirin is very good, but will not be good for everyone. And if we can tell the patients what is your likelihood of responding to the drug, what is your likelihood chances of developing side effects, the patient, that's in personal medicine, can decide. So we should give him the information, he should make the decisions. And I'm going to show you some data. Okay, it was a joke. Okay, Aspirin is effective if you take it every day. If you take at least 2 tablets per week. Aspirin is effective after a decade of use. It's remember, usually we do not have that patients, but we can see the effect at least 5 years, preferably after a decade. Aspirin is effective, is decreasing the incidence of proximal colorectal cancer, as you can see it here. Overall, it's 24% reductions for proximal colon, 55% reductions, does not affect the distal colon. Strangely, it does has effects also not statistically significant in the rectum, so maybe it's not. Remember, we have seen earlier today that colonoscopy is very good for the left colon, and I think this is very thing that we should try to do, to combine between aspirin and colonoscopy. Maybe we shouldn't be this or that, maybe we should combine the both. But definitely aspirin is significantly better for right-sided lesions. Aspirin is effective only when the adenomas express COX-2. So we have seen some about the genetics. Also, it depends on the type of the tumor. If COX-2 is not expressed, it is not working. Aspirin is effective only when there is wild-type BRAF, and also we have seen some of the pathways earlier this morning. Aspirin is effective only when the tumor has a mutant PIK3. So, wild-type BRAF, mutant PIK3. Just a recent paper from the New England Journal of Medicine and another paper. I didn't have time to show you. It's only effective you can find high levels of prostaglandin metabolites in the urine. It makes sense. Aspirins inhibit the prostaglandin synthesis, inhibit COX-2. It's helpful only if this enzyme is working in our body. So I think when we have to carefully choose these patients, we can definitely maximize the efficacy of our patient, and we can find high risk and low risk patients. So what do you do? So definitely in my mind, when you have somebody with high risk for cancer, like patients with familial polyposis, HNPCC, with a lifetime risk of 80 to 100% of having colon cancer, there is no doubt that they should receive aspirin or any other non-steroidal anti-inflammatory drug. What do you do about those with moderate risk, personal or family history of colon cancer with a lifetime risk of 10 to 20? Well, I guess I would suggest yes, depending on some other factors like we have just alluded. What to do in the general population? 30 to 50% incidence of adenoma, about 5% incidence of colorectal cancer. Lifetime, obviously, diet risk, tobacco avoidance, limitation of alcohol, screening, aspirin. Maybe we should try to identify those high-risk populations. Those are smokers, those are drinkers, sedentarians, those are consuming red meat in large quantities, any specific genetic profile. We have just done, this is a driver score who, based on a few simple parameters, can predict the likelihood of somebody to develop colon cancer. Those who have 9 to 10 points have a 15% chances as those who are 0 to 3 points. So just simple parameters we can predict who is going, and those may be those who should receive aspirin. I a little bit modified it, and we just did some genetic analysis, and by just checking for polymorphism in the APC genes and CD24, we're able to improve this driver score. But ladies and gentlemen, I would like to sharpen one important point. When a patient is coming to me, he wants to live longer and better if possible. He doesn't care if I'm going to prevent colon cancer but cause him to die from bleeding cerebral hemorrhage. He wants to live longer. And there are 3 major killing diseases nowadays: cardiovascular, cancer, and Alzheimer's disease. And you can see it here that aspirin can prevent not only colon cancer, but also other cancers like esophageal, lung, as we said, almost all of them. And you can see it here, all solid tumors. Clearly beneficial effect of aspirin. So what I mean about personal aspirin. So if there is high risk for cardiovascular disease, there is no doubt this patient should be put on aspirin. If a patient is high risk for colon cancer, like we said, HNPCC, familial polyposis, any other polyposis, no doubt, aspirin or NSAIDs. Somebody with high tendency for Alzheimer's disease, strong family history, and now we know some mutations, most probably, we should discuss it, but most probably I would give him aspirin. What about the low risk? Low risk means somebody that, according to the Framingham study, has less than 10% chance of having myocardial infarctions in the upcoming decades. Somebody with low colorectal cancer, meaning no symptoms, no family history, and just a recent negative colonoscopy, and those with low chance of having Alzheimer's, they should not be put on aspirin. This is the two ends. What about the middle? So with moderate risk for ischemic heart disease, in the next decade they have a 10 to 20% chance of having a myocardial infarction. It is not known in the literature, it's debateful. So I think if they have low risk for colon cancer, low risk for Alzheimer's, I would discuss it with the patients, but most probably my gut feelings, and as a gastroenterologist I'm entitled to say it, I would not recommend them aspirin, but it should be patient decision. If it choose, then we have to take that it mostly his colon cancer should be in the proximal colon and should express COX-2. If he has the medium risk for colorectal cancer, medium risk for Alzheimer's disease, again, I would discuss it, but my preferential will be to, yes, let's put him on aspirin. This is the most difficult one. Those with medium risk for colorectal cancer and medium risk for Alzheimer's disease or low risk for colon cancer, then again, discuss it with the patients, and I do not give a equal, and it really depends on the patients. Genetic polymorphism is very, very important. We just had a paper, Nelly, she always takes the good stuff to tell. It's amazing. No, I'm just joking. But it's based on a study. It's based on a study that I was a principal investigator with Bernard Levine. It's called the PRECEPT study. And we can see we use a COX-2 inhibitors in order to prevent adenoma recurrence. And you can see that across the board, overall, after 1 year, 3 years, with aspirin, without aspirin, advanced adenoma, there was a clearly beneficial effect of COX-2 inhibitors. It's pity because of some side effects, not in our study, some other studies, the entire field was abandoned. It is pity, but maybe with the result, and that Nelly is going to tell us about the result of our study, we might be back on track. So, ladies and gentlemen, very strong evidence exists for a cancer-preventing effect of low-dose aspirin, particularly if taken every day for at least a decade and for right chronic lesions. Future benefit-risk balance should take all benefits and risks into account to provide optimum guidance, and it's also including the genetics. In particular, aspirin can serve as a magic bullet with its primary and secondary preventive benefits in cancer, vascular, and Alzheimer's disease. Genomic and neoplastic molecular signature will help us to choose the right patients. Thank you very much. I think this is also very important.
Thanks, Nadir, and I think you had wonderful stuff. So even though I took a little part, are there any questions? Maybe I'll add one piece of data that I know based on advisory board. The question is how long one needs to take aspirin. It looks like it may actually be only 5 years for having effects for, like, just delaying carcinogenesis by about 10 years. So it really may be a very time-limited approach, but none of this is known at this point. Nadir, so maybe you can comment a little bit about your trial that you just had the last words about, because I'm not sure whether everybody in the room, some of them are younger, knows what actually happened in the celecoxib trial.
So this was study which used celecoxib. It's a specific COX-2 inhibitor with Serial, Pharmacia, and eventually Pfizer. We gave it to patients with adenoma, so we scoped the patients, we found adenoma, we took it out. We took not those tiny adenoma, but it has to be at least 5 millimeters or more than one adenoma, 2 adenomas. So we recruited these patients and we gave them placebo or celecoxib for 3 years. It was 1,561 patients from 110 countries across the world, everywhere. And we scope the patients after 1 year, after 3 years, and then the patients continue for another 2 years on study, but off the drug for another 2 years, and then we did another colonoscopy after 5 years. As you can see, the efficacy was seen across the board. It was very effective, between 36 to 50% reductions in adenoma recurrence, especially advanced adenoma. The problem is that a sister study that use also celecoxib, it calls APC, and the Vioxx, which use another study that use, approved study that use Vioxx, some unpredictable cardiovascular toxicity was seen, not in our study, but in the other studies, and then it was a decision by the FDA and by the companies to stop these studies. It was not justified because it was really small number of people, but, and there is some cardiovascular toxicity for COX-2 inhibitors, now I'm convinced, but if you see the efficacy, the magnitude of efficacy, and based on, Nelly is going to show, we can tell which patients are going to develop this cardiovascular toxicity. So obviously this patient should not be put on COX-2 inhibitor, but the rest, the COX-2 inhibitors are very good drug for relieving pain, fever, but also for cancer prevention. But it was such a big hysteria worldwide, American hysteria, if I may say, that the entire field was abandoned. We can do, but I think that depends on what we are doing, and I strongly believe in personal medicine. If we can predict the likelihood of somebody to develop cancer and the likelihood of him of having to respond to a drug and to develop side effects, then it's not a problem and not an issue to prescribe it. And aspirin might be the answer because it can, like I'm saying, the mistakes in all studies that are reporting that we are focusing on one organ, one disease. But the patients do not care. They just want to live better and longer. And we should look for overall morbidity and mortality. Thank you.
I think that was a very nice concluding word. Is there a question? Yeah, okay.
I would be interested in the percentage of people suffering from side effects by taking aspirin for cancer prevention. For me, it seems very high, the daily doses of 300 milligram.
I think that 100 milligram might be sufficient because you take it for the long run. Actually, and we have some studies, especially Francis Chen from Hong Kong, which I know him very well, that the profile of side effects is not that much. When you compare between the placebo arm and the aspirin arm, obviously there is more in the aspirin arm, but not that much. And if you take into considerations like protecting the mucosa, like eradicating Helicobacter pylori, when needed to give a PPI, I think we are going on a safe ground. And we have to remember that we are preventing major diseases. So there might be a small price, but very, very few, if at all, people are dying because they are taking aspirin. And when we are trying to eradicate Helicobacter pylori or use PPI when it's indicated. There was some even fascinating paper that coming from the Hong Kong group when patient had a bleeding ulcer. So when they treated them well, because they needed aspirin for severe ischemic heart disease, so the outcome was better to those who continue to be on aspirin plus proton pump inhibitor as compared to those who stopped aspirin because they died from ischemic heart disease, from myocardial infarctions. So we have to take it into cautions like this mouse, but we have to take a calculated risk. And I think that the side effects, and especially we have to remember that 95% of the side effects appear within the first months of therapy. And if somebody has passed this period, then he should be completely safe.
A question from a gastroenterologist to a gastroenterologist. Did you see ever a severe GI bleeding under 100 milligrams of aspirin? I ask this behind the question that we every time will be asked before colonoscopy, should we abstain from aspirin if we have a polypectomy? And we do not. We do not recommend to set away aspirin when we do colonoscopy and polypectomy?
No, I agree. It's very rarely. It's a rare event, and I think that what we say when even if it's a bleeding patient, we know how to stop bleeding. It's much more difficult to treat the thrombosis. You have a thrombosis in the myocardial infarction, then it's difficult to treat. But even if we have a bleeding patient, we know and we have the tools how to treat it and to stop the bleeding.
So I think in the interest of...
I have a question. Just a short question. Are there any studies on other NSAIDs like ibuprofen or something? And if yes, what are the differences, especially regarding the side effects?
I think other NSAIDs are definitely very good in preventing adenoma recurrence, treating cancer, that's good. But they do not have this protective effect about the heart. So I think if somebody is looking for a drug that can be both for overall, then aspirin is better. Definitely does not have what some of the NSAIDs and COX-2 inhibitors have, this cardiovascular toxicity. If you have to think about something, that they might be a better drug. But obviously, and I've shown in my first slides, non-steroidal, this is 70 out of 72 trial. The protective effect of NSAIDs and aspirin was clearly shown.
Okay, so thank you. I think we'll have more opportunity to discuss after we have the next speaker. Thank you very much, Nadir. And Gabriele Möslein is now